Welcome to the Overview of Fibromyalgia, Myths, Facts, and Future Hopes webinar. We're glad you're here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by ourselves, CIRPD, and Pain BC, in collaboration with the Canadian Pain Coalition. And it's also been made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya, and I'll be moderating the session as well as handling the question and answers at the end. And our presenter today is Connie Luedtke. Connie is a assistant professor at the Mayo Clinic College of Medicine, as well as a nursing supervisor at the Mayo Clinic Pain Rehabilitation Center and Mayo Fibromyalgia Chronic Fatigue Clinic. She has worked at Mayo for 29 years, and 25 of those years have been with chronic pain patients. She is certified in pain management nursing and has been active within the American Society for Pain Management Nursing, particularly in the field of advocacy. So I'd like to hand it over to you, Connie.
Thanks for that great introduction, Tanya. And I am happy to be here with all of you today. Our good neighbors to the north. I am located, I believe as Tanya said, in Rochester, Minnesota, where we too have long, cold winters. It is now about 45 degrees and raining with a threat of snow tonight, and I do believe that spring will come eventually. So my objectives for the day today are to take you through some myths, facts, and future hopes in regards to fibromyalgia. After completing the session, you all should be able to list one difference between the old and new criteria for diagnosing fibromyalgia, to identify two components of sensitization that may be present in people with fibromyalgia, and to describe at least 3 skills that may decrease symptoms or improve functioning in people with fibromyalgia. As I was preparing for this webinar, I did a little bit of searching on the web, and I found here a colleague from the Canadian health system, Dr. Barbara Keddy, and I actually ordered this book that you see the cover in the middle here, Women in Fibromyalgia. And it was a very interesting book. I haven't finished it yet. I ordered it just too recently, but it was an excellent resource for me to see a little bit about your information in this regards in the Canadian health system. I've put up a picture here of the princess in the pea because I think that is a good description of what many people feel like when they have fibromyalgia. They feel like anything out of the ordinary, any maybe an extra touch or different kinds of sensitization, if you will, or feelings are much more exaggerated for these people than they might be for others. And I also put a picture of Florence Nightingale up here, Notes on Nursing. There are many people in the field of nursing, including Dr. Keddy, who suspect that Florence may have suffered with fibromyalgia herself. So I thought that this was kind of an interesting few pictures to get us started with here this afternoon. So fibromyalgia is known as a syndrome, and that's different than a disease. So a syndrome is a fairly consistent pattern of symptoms that are seen in people with the same medical disorder or the same diagnosis. Unfortunately, there's no defined cause, and a syndrome is more difficult to treat than a disease. Some facts about fibromyalgia is it is not life-threatening. It is more commonly diagnosed in women than men, and it may coexist with other treated medical conditions. Now, I believe that men struggle with fibromyalgia probably in equal to women. I just think that it's not diagnosed as frequently, and we'll talk more about that here in a few slides. Some other facts about fibromyalgia. The symptoms can fall on a spectrum. Sometimes people will have all of these symptoms, other times they just have a few. But generally, most people with fibromyalgia complain of pain. It can be described as a stiffness or maybe a generalized flu-like achiness. The pain sites may migrate, so maybe some days or even for months at a time, the pain might be located mainly in the hips, perhaps. And then the pain might get better in the hips, and then the shoulders might be more irritated. And that might migrate to chest pain, which is very difficult to determine, at least when this is a new symptom, whether or not this is cardiac chest pain or if it is fibromyalgia chest pain. So it's very confusing for people who are struggling with these symptoms that are new symptoms for them. Many times people also complain of numbness and tingling in their hands and their feet, their fingers, their toes. Fatigue is another very common complaint of people with fibromyalgia. And there are many, many other symptoms. We'll talk more about that in detail. Where I work at the Mayo Clinic, we see that there is a continuum of pain and fatigue. Sometimes people will come into our clinic and they're complaining mostly of fatigue, whereas other people come in and their complaint is mostly pain. But when we do a full evaluation on them, often we will see that patients can be diagnosed with fibromyalgia and possibly even chronic fatigue syndrome. As this slide shows, there is a continuum, and fibromyalgia we describe as a chronic widespread pain, fatigue, unrefreshing sleep, and problems with cognitive and affective or mood complaints. Now there's also chronic multifactorial fatigue. Now this would be patients who maybe they have multiple medical conditions and they have the pain, they're diagnosed with fibromyalgia, but there are reasons that they could be diagnosed for fatigue. So that precludes them from getting the diagnosis of chronic fatigue syndrome. So I'm going to jump to that one. In chronic fatigue syndrome, that's defined as a physical and mental exhaustion of unknown etiology that profoundly impacts the physical, occupational, social, or psychological function of the person. So in order to be diagnosed with a chronic fatigue syndrome, you really have to rule out any other possible cause of fatigue. So it's pretty difficult to get that diagnosis of chronic fatigue syndrome. However, the majority of our patients carry a diagnosis of both fibromyalgia and chronic multifactorial fatigue. And by that we mean a chronic fatigue or chronic tiredness that may be related to chronic conditions, such as diabetes or maybe another kind of chronic pain problem. It could be from physical deconditioning, from sleep problems, or again, mood-related issues. In the majority of cases, there are multiple contributing factors to this person's fatigue. Pardon me. So in 1990, the American College of Rheumatology established a diagnostic criteria in order to come up with what fibromyalgia is. Now, it was initially set up to be criteria for researchers. So it wasn't in the clinical situation, but for researchers. And they have revised that. But in 1990, the criteria included widespread pain on both sides of the body and above and below the waist. And that pain needed to be present for at least 3 months. And they had to have at least 11 out of 18 so-called tender points. Now that's a misnomer because these points are more than tender, they're painful. If you were evaluated, and many of you have been, if you've had a tender point examination at any of these points on the body, the front and the back, you'll notice that when the providers will assess this, they use a fair amount of pressure. And for anybody, even without the diagnosis of fibromyalgia, there's a sense of tenderness because these are at muscle insertion sites. However, with people with fibromyalgia, these areas are painful. They're painful to the touch. So tender point is a bit of a misnomer. Now, in 2010, the American College of Rheumatology came up with a revised criteria. And what we have seen clinically is that this newer criteria allowed more men to be diagnosed with fibromyalgia. I'm going to back up here a little bit. So the 1990 criteria said there needed to be 11 out of 18 tender points. Clinically, what we would see is most of the men that would come into our clinic would have pain that's widespread, and they'd have fatigue and many other associated symptoms, but maybe they only reached 10 of the required 18 tender points. So now with this new criteria, we are seeing more men that are diagnosed with this. So the new criteria for fibromyalgia include a widespread pain index, a level of symptom severity looking at 3 factors, and that includes fatigue, feeling that you wake up unrefreshed, no matter how long you may have slept or been in bed. When you wake up or get up in the morning, you have this feeling of being unrefreshed, and cognitive symptoms, which could be like this fibro fog or difficult with word find or anything related to the cognitive domain. There can be many additional symptoms that are associated with this, and these symptoms need to be present at a similar level for at least 3 months. Now the form that you see up here is something that we've developed here at Mayo, and it's based on the new criteria. So in order to do this, we have patients check in the first little table there what kind of pain you've had in that area for the past 7 days. So kind of to indicate really the areas of the tender point that we showed here in this previous slide. Those are all listed in this table. Then the second question is, which of these symptoms have you frequently experienced in the past 6 months? To get an idea on that. And then there's a scoring system looking at the severity of the symptoms for the fatigue, waking unrefreshed, and cognitive symptoms. And those are determined after the provider interviews the patient and does a physical exam with them. So that is combined with this form that is listed here on the screen. So what causes fibromyalgia? Well, we really don't know. There's no single event that we are aware of that causes fibromyalgia or chronic fatigue for that matter. We believe that there's a combination of physical and or emotional stressors. And it is considered a disorder of pain and or stress regulation. So there's a disorder or a malfunction, if you will, in a person's body, in their nervous system. This diagram is based on an article from Mohammed Yunus in 2007. It's a simplified version, but it's a biopsychosocial model of contributing factors to fibromyalgia. So I'll go through this in a little detail. So there's, of course, the caveat of other factors down at the bottom left-hand corner here, that there's many possible unknown factors. But we hear stories from the patients that come to our clinic, and this is internationally reported in the literature, that many folks will say that they had no problems with pain or fatigue until they had some sort of an infection. Sometimes it's Lyme's disease or mono or H1N1, but some sort of an infection or an inflammatory process that seemed to trigger the symptoms for them. For other people, their story begins after a physical trauma, and this could be a sporting injury, maybe as a youth playing soccer, for instance, or a cheerleading accident. It could also be something like a car accident or even a surgical trauma. Sometimes people will say, I was fine until I had a hysterectomy, for instance. So there's a number of factors there, perhaps the hormonal as well as the surgical trauma. Now in the top left-hand corner, we see sleep as a contributing factor. Now we know that poor sleep is a result of fibromyalgia, but it can also be a contributing factor. Again, we hear stories from many folks that say, you know, I was burning the candle at both ends. My job was requiring a lot of me, my family was requiring a lot of me, so I went for a period of time where I was living on 4, 5, 6 hours sleep, and that definitely can be a contributing factor. We also know that there is a genetic predisposition for fibromyalgia. We don't know what specific gene, but we know that tends to occur in families. Those of you listening who may struggle with fibromyalgia, you may know of a family member who also struggles with the same condition or similar problems, chronic pain problems or sleep problems or fatigue. There are other dysfunctions along the autonomic nervous system that contribute to fibromyalgia type of pain as well. And many psychological factors, such as stress. Again, referring to patient stories, they might say, you know, I was doing fine even after I had that flu or that car accident. I seemed to be doing okay until my mother got sick and I had to take care of her. And just the stress of taking care of her, plus my own family, plus working, that stress was just too much for me to handle. And that was a huge contributing factor. Still, for others, there seems to be factors from their childhood, neonatal or childhood trauma, often physical or sexual abuse or neglect can play a role in this. And finally, the last on the bottom right-hand corner are environmental noise and chemicals. All of these also can have an impact on our physical body. Maybe the foods that we eat, living in the middle city, center of the city, and a lot of noise or pollution. All of those things we suspect play a role. And as you can see, these arrows all point to the center where there's a hyperexcitement of the central neurons. So that triggers your body. Your body's kind of in a hypersensitive state, which can lead to a phenomenon called central sensitization. And we'll talk about that in a little more detail here. This is just a slide to show you how complicated fibromyalgia can be. Each of these can be a symptom of fibromyalgia, and really if any of these symptoms becomes more predominant than the other, it's kind of like a table that has 4 legs, and if one of the legs gets longer or shorter than the other, the rest of them are all out of whack. So you can take your pick of any of these symptoms, and if you have more sleep problems, that's going to contribute to a decreased mood and also to more fatigue and probably to pain. Or if your pain is increased, you're going to sleep less and you're going to feel more fatigued and you're going to be more ornery. So just a model of how complicated the symptoms of fibromyalgia can be. Now, in order to talk about central sensitization in a little more detail, to make sense of that, I want to back up a little bit to what you all may recall from high school, a little bit about our autonomic nervous system. Now, our autonomic nervous system has 2 branches. There's the sympathetic branch and the parasympathetic. The sympathetic is depicted on the right-hand side of this diagram, and that is what initiates our stress response. So imagine perhaps that you are a passenger in a car, and in the driver's seat is your 15-year-old child who has his or her driving permit. And maybe it's your 2nd or 3rd time out with them, and you're driving and you're going down a one-way street, and maybe it's bad weather out, it's raining or it's snowing, and you're trying to keep your cool and be the good parent as you're teaching your child how to drive, and suddenly you see headlights rushing towards you on this one-way street. So obviously they're going the wrong way. That is going to initiate a huge stress response. You're thinking, oh my gosh, I'm going to die. My child is not prepared for this, and I'm not prepared for this. So all of these things happen on the right side of your screen. Your sympathetic nervous system goes into the fight or flight mode. So your pupils dilate, your heart beating is accelerated, your muscles are preparing to either fight or flee. So included in that, your lungs are able to take in more air, your body's converting glycogen to glucose, so you have that ready energy. Your body is also secreting adrenaline and noradrenaline. And that's the way our bodies are supposed to work. Now let's say in our imaginary story here that your son or daughter, without you knowing it, had played a lot of video games that were related to driving, and they were just an expert driver. So even though this car was coming at you full go, your child expertly maneuvered to the side of the road and put it in park, and the car drove by, and you guys are both giggling and whatever it is you're doing, and you're wiping the sweat from your brow and saying, wow, we dodged a bullet. What's supposed to happen with your bodies then is your parasympathetic nervous system is supposed to kick into gear, and that initiates the relaxation response. So your heartbeat slows down, your pupils go back to the normal size, your breathing slows down, your body's able to focus on peristalsis now, and that balance is the normal process in everybody's functioning of the nervous system. Now, the theories about central sensitization is that there is a imbalance, that is created by chronic stress. And perhaps all of these factors that we talked about before, all of these contributing factors cause this hyper-excitement in your central neurons, leading to a central sensitization. Now here's a diagram to show you how this might happen. So on the axis on the left is an imaginary stress level response, and across the bottom is time. And we have an imaginary red line that's a breaking point. Whoops. Sorry. So here, the green line shows a body's normal response. So the S is indicative of the sympathetic. And every day we have something that triggers us many times a day. So a little bit of a sympathetic response might be not hearing your alarm, so you're running a little bit late for work. But your body adjusts itself to that and you go on. And then another one might be, oh darn, you spilled coffee on your pants and you have to change, and again you're delayed for work. Another one might be the boss calling you into her office to say we need to talk. All of these are little sympathetic triggers in our autonomic nervous system. And if your body's working the way it should, that green line goes back down to the baseline because your parasympathetic creates that balance. Now, even if a person goes up to this imaginary breaking point, say your spouse asks you for a divorce, and that is an imaginary breaking point, our bodies should be able to bring it back down. The parasympathetic should automatically bring that stress response down. But the theory of central sensitization kind of goes like this, that this chronic stress can change the level of your body. So you might still have these same level of stressors with the sympathetic. I'm trying to point with my arrow here. Hopefully you can see that. But even this little bit of a stress, when you look across, is a heightened stress response because the body's not going back to baseline. So this red line goes up and up and up. Your body is not going back to the baseline. It's not resetting itself. So central sensitization is thought to be an increase in the excitability of the neurons within your central nervous system, which is, as you can see in this picture, it's your brain and your spinal cord. Now there also is such a thing called peripheral sensitization, but that would be from your spinal cord to your muscles and tissues in the body. And for today we're focusing more on the central sensitization. So this hyperexcitement of the neurons within your central nervous system can result in an abnormal enhancement of pain. So you can feel more pain than the next person. So say we have two people with a chronic pain condition. Maybe one has central sensitization and another one doesn't. The one with central sensitization is going to experience that pain differently. And sometimes we'll hear people that come into our clinic that will say, you know, my doctor doesn't seem to understand it, because he'll say, well, I take care of lots of people with this kind of pain and most of them don't, they seem to be healed by now, or they don't complain of the same level of pain as you do. Well, that's probably because they don't have that central sensitization involved. So there is an abnormal enhancement of pain and also general hypersensitivity. So what does that mean? Well, that means that a person can be sensitive to other things besides pain. Most frequently what we hear will be things of the nature listed on your screen here. sensitivity to light. Maybe people close their shades or their draperies more often, or they are wearing sunglasses inside the house. Maybe sounds are more difficult for them. And smells is a common complaint of people with fibromyalgia. They can't stand the smell of perfume or even perfumed shampoos or soaps. And things like carpet glue and paint can be really bothersome to them. Also, people will say that they have general stress intolerance. Maybe in the past they could pride themselves on handling a lot of stress and multitasking and being able to manage quite well. But at this point in time, any little stress seems to bother them, whereas in the past it didn't. People with fibromyalgia will also say that a gentle touch can cause pain, and that the pain that they feel is more than what others seem to experience. Sometimes people will say that foods bother them. They have to give up their spicy foods or change their diet. And often, these are the kind of folks that will have maybe not true med allergies, or in addition to medication allergies, they have a ton of sensitivities to medications. They've been tried on this dose or that medication and they can't tolerate it. So often providers will have to order a lower dose of that kind of medication. So with central sensitization, we see an overlap of a lot of syndromes. Now, as Tanya said, I've been in this field for about 25 years now, and I've kind of seen that this understanding has grown over time. I remember being at some conferences where we'd have people that wouldn't usually attend that particular conference, and they'd be saying, you know, there's so much overlap between my patients with interstitial cystitis as there are with the folks here with fibromyalgia. So I'm going to go through and kind of briefly discuss the different types of syndromes that are listed on the screen here. At the top we have fibromyalgia and myofascial pain. Going counterclockwise, then there's fatigue, and that could be chronic fatigue syndrome or multifactorial fatigue. Interstitial cystitis is a problem with irritation of the bladder and anything along the urinary tract. So it might mean running to the bathroom frequently, but maybe only being able to urinate a little bit, and that constant burning and discomfort associated with that. Irritable bowel syndrome is the same kind of problem, only related to the bowels, and there can be both diarrhea and constipation associated with this, as well as bloating and gas discomfort. Migraines and tension headaches can fit into this overlap of central sensitization, as well as temporomandibular joint pain. Many chronic pain problems fit into this category, including diabetic neuropathy, complex regional pain syndrome, general chronic back pain, you name it, and it can fit into this criteria here. Now I want to take just a minute and talk about POTS, which is postural orthostatic tachycardia syndrome. At the Mayo Clinic here we have a pediatric pain rehab program as well as an adult program. And over the last couple of years we've seen a lot of youth from ages 12 to young adult, 21, 25 age, who come in with chronic headaches and abdominal pain, but they also have fainting spells. They become dizzy and faint, and sometimes they injure themselves. Usually it's fainting without episode. And this POTS also fits into the central sensitivity syndromes. Multiple chemical sensitivities or Gulf War syndrome can fit in here, as well as restless leg syndrome, and many types of depression and even post-traumatic stress disorder also fit into this. Now, this is not all inclusive. If you go to this article by Mohammed Yunus in 2007, you'll see many more conditions or syndromes that are thought to line up into the central sensitivity syndromes. Now, this is just a review of how a person feels acute pain. So this is the way, again, our bodies are supposed to work. We encounter a source of pain. Maybe we accidentally touch a burner, and that pain source sends electrical nerve impulses from the site to our spinal cord. And the nerves in the spinal cord then release chemicals that either amplify or subdue these pain messages. And the brain interprets this message as pain. Now with chronic pain, it's a little bit different. So sometimes we know the chronic condition or the injury that started this pain off, but sometimes it's unknown. People just don't understand what's caused this, and fibromyalgia could fit into this category. So now with chronic pain, these nerves are misfiring and they're sending wrong messages. So there's a possible chemical imbalance that affects the pain response. So on the image here on your screen, you can see that substance P, which is the name of a neurotransmitter, a neurochemical that causes pain, that increases. And also the serotonin and norepinephrine that is supposed to dampen the pain, that decreases. So people with chronic pain really have a double whammy. They often have more substance P and less serotonin and norepinephrine. And all of that contributes to a pain response. Now it's important to notice that whether it's acute pain here or chronic pain, your brain is interpreting this message as pain. It's real pain, it's physiological pain, but it gets there through a little bit of a different mechanism. Here's another graphic for you. So imagine, rather than touching a burner here, this person is poked with a pin. And the way your body goes, those nerve sensations go from this finger to the spinal cord and from the spinal cord to the brain. And the brain perceives this as pain. Ouch, I just got poked in the finger with a pin. Now, if there is an imbalance of the neurochemicals, and it could be more substance P, and it can be less of the serotonin and other neurochemicals, somewhere between the spinal cord and the brain, there's an imbalance. There's a misfiring of those nerve endings, and they cause the brain to perceive a greater amount of pain than it should. And over time, even things that shouldn't cause pain, like this woman hugging her grandchild, that sensitization, if you will, creates the same effect in the brain. So it causes pain. So in our brain, our neurons fire and they synapse with one another. So here's just a diagram of a couple neurons and the release of perhaps that substance P. And repeated signals can create what's called a memory pathway. So here's a bunch of these neurons interacting with one another. They're firing and they're connecting. And we like to say that those nerves that fire together wire together. So they create this memory pathway. So what that is called is neuroplasticity. And this is a picture of nerves that are, the connection is growing from left to right. So that pathway starts out just very minor on the left-hand side, and the connections grow from left to right. And that can both be a bad thing as you create a pain pathway, but it also can be a good thing as you're creating a new pathway. Now, I just found out today that YouTube videos don't work here on the webinar, so I apologize that I can't show this. But this will be present on your handouts, and you can go to the YouTube link down below here. And this is a good example of neuroplasticity, and it helps kind of understand how this pathway is created, that there are gaps in the synapses in our nerves, and your body kind of fills in the gap. That's what's happening from left to right here, to make the signal's journey easier. So that happens as you're feeling pain, but it also happens as you're learning new and other ways to manage your pain. So right now, those of you who struggle with fibromyalgia or chronic fatigue or any of those central sensitivity syndromes, right now your nervous system looks a bit like this, a superhighway, which is pretty overwhelming, isn't it? And we know that there are certain things that trigger these pain impulses. Now, it's not a pretend pain impulse, it's a real pain impulse, and it leads to more pain. What we want to help you all do is to make your pathways more like this, and isn't that a much more pleasant scene? Not only the path to the left, but even perhaps the path to the right. A new and uncharted territory. So you don't have all of those unfortunate connections to look like this superhighway. So in order to help you do that, we want to focus on what you can control. And so for providers that might be on the webinar with us, that means shifting gears from necessarily, finding what the cause is and finding that fix, but instead helping the person with fibromyalgia get control of their life again. And we do that by focusing on what you can control. Your activities of daily living, making healthy choices, how you respond emotionally to things, and balancing the use of time. We all have 24 hours in a day. How are we going to choose to use that time with our family, our leisure life, our work, engaging in exercise, or in our spirituality? So here is a wheel, a colorful wheel that talks about many, many different types of what we call self-management tools. Now, all of these are available to each and every one of us, but it doesn't mean that we can all immediately leave this webinar and we're going to have a perfectly balanced, color-coordinated life. No, of course not. Nobody's life is like this. But this is here for you to see that there are many options for you to use, other than just going to the doctor and finding the perfect medication. So what is self-management? Well, it is a holistic approach using our body, our mind, and our spirit to decrease the symptom burden and to improve our quality of life. And this seems to be the key to living well in spite of being diagnosed with fibromyalgia or chronic fatigue, or for that matter, any sort of chronic symptoms. On this side, we have both amplifiers and dampeners. And if you can recall back to a slide before when we had the substance P and the serotonin on the slides, that we know that your body produces more substance P when you engage in some of these amplifiers listed on the left. So the more muscle tension you have, the more you have poor sleep, negative thinking, all of those things can amplify your body to produce more pain. We also know, thankfully, that there are ways that we can decrease the production of that substance P and also increase the serotonin, norepinephrine, and the more feel-good neurochemicals. And those are listed here on the right side: the relaxation, regular exercise, good sleep hygiene, not focusing on the perfectionism, having a positive outlook, humor, and the list goes on. I'm going to keep moving. I might be a little bit behind on the time here, so I'm going to keep moving forward a little. I want to talk for a minute about symptom-focused behaviors. So what I mean by that is things that people say or do or avoid saying or doing that reminds them and alerts other people that they're experiencing pain or fatigue. And when we start out with a new symptom, say we have an acute pain problem, these things can even maybe make you feel better. So for instance, if I sprain my ankle, I'm going to put ice on it, I'm going to elevate it, and I might rub it, I'm going to go to the doctor, and all of those things might help heal my acute sprained ankle or broken bone or whatever it is. But as the weeks and months go on and the tissue should heal, putting ice on it really doesn't do any physical benefit for my pain anymore. And it can be just a reminder of this chronic problem, this chronic pain in my foot or my leg. Now we know that focusing on these symptoms actually signals your brain to produce more substance P. So the more you think about the pain or the more you rub that area, the more that substance P is created. So it actually makes your pain worse. And responses from others can also make that pain worse. So here I have I thought this was a cute picture, Pain and Panic from Disney, and those are the characters from Hercules, and I think they go hand in hand together. If any of you have had a really difficult day of pain, even if you're a provider and you're not diagnosed with fibromyalgia, we can all relate to having a difficult day. And if we have that urge to panic, it's going to make us feel worse. And we know that things like distraction can help. What we haven't known until recently is that there are tests such as MRIs and PET scans that can help us see that there's an actual chemical reaction that happens. The more we think about our pain and our symptoms, the more that substance P is released, and the less of that serotonin that's released, so therefore the worse that person is going to feel. Now we know that this is a learned behavior. The good news is that it can also be unlearned. We can learn not to pay so much attention to the symptoms that we feel. Now again, here's another YouTube video that unfortunately I can't show. But what this shows is a visualization of a person experiencing pain. Now this was a study that was done in Stanford, I believe, and the researcher was teaching patients how to use a functional MRI scan where they had a screen in the scan with them or that they could look at, and the more they thought about their pain and talked about their pain, they could see that areas in their brain that produce substance P light up. It would be highlighted. And likewise, when they were engaging in relaxation or distraction or telling jokes, that area in the brain would calm down, would quiet down to nothing. And they also saw that later then they could activate and trigger the serotonin and the feel-good neurochemicals. So if you get a chance, go onto this YouTube and look at how your brain looks when you're thinking about your pain. Now there were other studies that have been done looking at the role of family members. So I'm going to jump to the second and third bullet here. So a functional PET scan was done with people who had chronic pain, and the same kind of thing, that they could look and see the more they thought about their pain and talked about their pain, the more the pain centers would light up. They had the family members just come into the room, and usually when I'm talking to a live audience, I'll ask, your opinion on whether the pain would increase or decrease with family members. So I'll let you just kind of give your guess on this. But it was almost unanimous, 100%, that the pain increased. And we believe that's because you associate your family members with people that you trust, and you can let your guard down and you can share with them how you really feel. So there needs to be a way to break out of that connection of, your spouse walks in the door, or your parent or your best friend or whomever, and you immediately think about how bad you feel. And there is a way to break out of this cycle. And this slide shows how we typically as family members respond to what I'm calling pain behaviors. First, we all start out on the left. We're solicitous. Again, think about an acute pain problem. So I break my leg and I'm home and my husband is taking care of me and he's making supper and he's cleaning the house and he's telling me I don't have to go to work, it's just really quite nice. He's really paying attention to me. But if that becomes a chronic pain problem and the weeks turn into months and I have to quit my job and he has to work double time, he might get a little ornery at me. So he's carrying on his full load of work and household duties plus mine. So it would be normal to jump over to the right hand of the screen to what we call punitive or punishing. So he feels like he's trying to help, but he can't. He can't make my pain go away. He's frustrated because he can't help. He's also frustrated because he's carrying on all these extra duties, and he feels like he's becoming more my care provider than he is my spouse. So he becomes angry and resentful, and he might snap and say something mean and storm out. But then the guilt will set in. Oh, how can I think and feel this way? Of course my wife is having terrible pain, and I'm such a horrible spouse, and why am I doing this? So then he jumps over to the solicitous again. And this cycle goes round and round, and it spirals downward. So one thing that we can do is to teach people how to have a neutral response. And that means not asking about the pain and the symptoms, assuming that the pain's always there because it's a chronic problem, but to talk about other things. So I'd want my husband to talk to me about how horrible the Vikings are playing, or the horrible weather, or talk to me about my son in college, whatever it is, something that's neutral, that is person-centered rather than symptom-centered. So a key is to build supportive relationships, again focusing on the person, not the symptoms. To strive for effective communication, being open and honest and assertive, not to that aggressive or punishing, and using I statements. Again, my husband can say, you know, I'm angry, I made supper, and you're not coming out of the room to eat with me, instead of, you make me so angry. And becoming the spouse again, or the parent or the best friend, rather than being the patient or caretaker role. So what about medications? Well, a little bit of a disclaimer. There is no magic cure for fibromyalgia. Medications can be helpful as a jump start. Some types of antidepressants can be helpful for pain and for mood and sleep enhancement. Beta blockers can be helpful to stabilize POTS symptoms, as I mentioned, that postural orthostatic tachycardia syndrome. That can be helpful as a jump start, but after a year or 2 years, then hopefully people can taper off of those. Anticonvulsants can help neuropathic type of pain, but we know that opioid use or strong pain medications really isn't the best treatment for fibromyalgia. And in fact, research shows us that it can contribute to what's called hyperalgesia, or increased experience of pain. Now, meloxicam, I'm sorry, I have the worst time pronouncing this, or Savella, is the latest drug to receive FDA approval for management of fibromyalgia. FDA is also approved with fibromyalgia indications for pregabalin or Lyrica and duloxetine or Cymbalta, and they were approved in 2007 and 2008. But outside of the USA, meloxicam already has a track record as an antidepressant. Now, it's similar to duloxetine in that both of these drugs increase the supply of the serotonin and norepinephrine, those chemical messengers or neurotransmitters that are more the feel-good neurochemicals. And meloxicam also gives your brain a larger boost of the norepinephrine, or more the feel-good dampening pain modulators. But ultimately, homeopathy or supplements, those kind of things, they may have a role, but research has not shown significant improvement with the use of those. So the treatment options that we encourage people to focus on is really that there's no magic bullet, and the sooner you can stop searching for that magic bullet, the sooner people are able to move on with their life, to stop searching for that fix or that cure. We know exercise is of utmost importance, but not going gung-ho, because then you do the push, crash, and burn cycle, but rather a graded, gradual exercise. And moderation is key to that as well. And there's two sides of the moderation coin. That means not overdoing, you know, like on the day you're feeling well and then you crash and burn, but it also means getting up and doing a certain amount every day, no matter what your level of pain or fatigue is. We see that a structured schedule is important. CBT, or cognitive behavioral therapy, can be very effective. Decreasing the focus on symptoms, and that's what we've talked about a little bit in previous slides. Helping people learn to manage their stress, and relaxation and sleep hygiene can be very active in the role of managing stress. Of course, eating a balanced nutrition diet, hydration is especially important with the fatigue and the POTS. Having a good sense of humor and a positive self-talk, and from family members that warm neutrality that can help you make the lifestyle changes that you want to try to implement. So in closing, I'm just going to leave up again the self-management tool here and show you the many options that you have to help manage your fibromyalgia or chronic fatigue. So as I wrap up here, the ball is now in your court. I leave you with a few references, citations from my presentation, as well as some more links. This Understanding Pain, What to Do About It in Less Than 5 Minutes is a very well done YouTube video that we show most of our patients here. So I guess that is the end of my presentation.
Great. Thank you very much, Connie. That was a great presentation, and I feel like there were a lot of practical tools in there as well as very informative points as well. So that's great. I'm going to go ahead and ask a few of the questions that have been sent in. And for those of you online, if you have more questions, feel free to type them in now, and I will do my best to get through them all. Let's see. Someone asked, who would be a specialist that's able to diagnose fibromyalgia?
So fibromyalgia can be diagnosed by any general practitioner. It used to be that people would go to rheumatologists, but now sometimes the rheumatologists won't even see patients that are requesting diagnosis. So any general practitioner should be able to diagnose it based on this new criteria from the American College of Rheumatology.
Very good. And someone else asked if there's an age that fibromyalgia starts, like a higher percentage at a certain age group?
We see it most often in women between the ages of 40 and 60, but we see it as young as 15, 14, and again, both with men and women. And as we hear people's story, it takes them about 5 to 7 years to get a diagnosis of fibromyalgia. That's because they may be going from specialist to specialist, and it takes a while for the person or the doctors to say, hey, there's a bigger picture here besides just carpal tunnel syndrome. So even though it might be diagnosed in that middle age range, when people tell us their stories, they'll say, gosh, I started with migraines back when I was 14 years old.
Very good. And then someone was asking about the American College of Rheumatology in San Diego presented a blood test that can predict fibro and stating that it's objective, accurate. Have you heard of this, and do you have any thoughts on it?
I did hear rumor of it. I wasn't at that presentation, and I think it was a small study, but I look forward to hearing more about that. And I as with most syndromes, as we do more research about it, we can understand the diagnosis better, and the researchers are likely to develop tools such as a laboratory test. So I look forward to learning more about that.
Very good. And then someone else was asking if there is a relationship between inflammation or swelling of the hands and ankles and feet and fibromyalgia.
Well, that's a good question. Oftentimes there's a sensation of swelling, and it goes with that peripheral numbness and tingling, but when it's actually measured, I have a sensation of swelling now and I don't at another time, there's really no measurable difference, but there's a huge sensation of it. But there can also be some inflammation as well. And it's hard to sort out, is that related to positioning or a person becoming deconditioned, which can contribute to swelling.
Gotcha. And then someone else was asking about the relationship between fibromyalgia and obesity.
Yes, there have been some research studies that have come out about that, and my feeling about that is that it's not necessarily a cause and a effect. It's this cycle, the chicken and the egg. Oftentimes people will gain weight because they're not able to exercise because they hurt so much. But there has been research that shows an association with that, and the greater the person's BMI is, and that's kind of your body mass index, the more severe your symptoms are. And that would make sense because it's harder to get around and to stretch or whatever if you're carrying more weight.
All right. And then someone else was asking about what good exercises you would recommend. Someone heard good things about jiu-jitsu as it teaches breath and handling pain, teaches you about breath and handling pain.
The good news is that there's no required exercise, no specific exercise, that you can choose whatever it is that appeals to you. And I think the key is to be really slow and purposeful about it. And I mean really graduated. We start some people out in our clinic at 2 minutes using a stationary bicycle. 2 2 minutes, and maybe doing that for a week or 2 weeks until you can feel like you can do that without getting exhausted. And then you increase it to 3 minutes or 4 minutes. But gentle stretching and some aerobic conditioning, and as you build up your tolerance, then to start adding some weight resistance, again over a long period of time.
Wonderful. We actually had a webinar a couple of months ago with a physiotherapist talking about graduated exercise and doing that type of work, so I will send that out as a resource for people as well.
Oh, that's great.
He had a very good explanation of it. Let's see, what else do I have here? Someone was asking about if you could comment about diffuse noxious inhibitory control.
I think that might be out of my domain in the last 2 minutes here.
All right.
Do you have an easier one?
Yes, I'm sure I do. Someone was asking about chemical sensitivities, but wondering if you've seen where long-term exposure causes the fibromyalgia versus chemical sensitivities being a result of fibromyalgia?
Definitely. Now again, I don't know that it's a cause and effect, but it certainly can be a huge contributing factor. Most definitely.
All right. And then someone else was wondering about the role of hormones in fibromyalgia?
Yes, again, that may be why initially it was thought as a woman's disease or a female syndrome, but we do see men that are impacted as well. But it seems to be many women will complain of the onset of symptoms either when they first start menstruating or also at the time of menopause. So we feel that there is a role of hormones in there, although again it's a contributing factor, not a cause, specifically cause and effect.
All right. And then someone asking about the importance of peripheral pain generator for maintenance of central sensitization?
Again, I think probably too much to get into this.
Yeah.
There certainly is connection between peripheral sensitization and pain generators and central sensitization. What I talked about with central sensitization in like 10 minutes here, we could have a whole 2-day session on. So it's very complicated, and what I gave was just a very simplistic overview. So I'm glad somebody asked that question. Again, a little too much to get into at this point.
Definitely. Thank you very much, Connie. That was a very good session, and I think that it will add to a great resource on our website and for people to access in the future as well.
Thank you for asking me to join you.
Wonderful.